Department of Medicine, did her clinical training and MSc focused on educational research at McMaster, has been Clerkship Director for Internal Medicine, came to UBC in 2003, Associate Program Director for Internal Medicine since 2005 to 2015, and since 2015, she is Director of CHES's Clinical Educator Fellowship and has extensive frontline experience as a clinical educator for undergraduate and postgrad learners, in addition to her experience with in-training and high-stakes assessment. She has research interest in peripatetic educational research. Main interests lie in work-based and high-stakes assessment methods. Okay, so welcome, Dr. Hatala, and Dr. Hatala is going to be talking about understanding coaching in clinical education and graduate supervision, and reflect on conditions to promote meaningful feedback conversations with learners. So the title is Coaching and Feedback in the Era of Competence by Design. Over to you, Dr. Hatala. And Jackie, at the end, I'll ask for, or I'll put forward your request, okay?
Perfect. Thank you so much. And please, everybody, just call me Rose. Nobody calls me Dr. Hatala, but I appreciate it. First off, I would like to acknowledge that I work on the traditional, ancestral, and stolen territories of the Coast Salish people. And particularly today, I'm coming to you from St. John Hospice. So that is on UBC, which is on Musqueam land. And I think it's really important, as we have our conversation today, really focused on coaching and feedback, that there's a lot we can learn from our Indigenous colleagues in this space. Many Indigenous cultures, one of the central tenets is about relationship. And as you'll see, and we'll come back to over and over and over in our conversation today, really a lot of making smoother feedback conversations, et cetera, is really focused on our relationality with our learners. I'm hoping today's session, I really want a conversation kind of bi-directional. I really don't want to deliver a lecture at you. That would be a bit weird. And if the feedback thing that's kind of based on conversation. So I've also made some pauses of places for us to have a chat, but please feel free just to speak up at any point. It's hard for me to see you, if you're trying to talk, so just go ahead and do that. Secondly, I know some folks here do graduate student supervision as opposed to medical students or residents. And I think despite our language that's particular in medicine, I think some of these things are very universal. So I'm hoping that that feels quite relevant. And then thirdly, I know we have lots of residents here, which is really exciting. So I want you as residents to think about yourselves. You're in this very interesting space because you can think about the things we talk about as the recipient, like being the learner in the relationship, but then you also have medical students and junior residents that you're teaching. So you can also think about yourself as teacher. And I'd love it if you would share your perspectives, whatever feels safe to actually share about your perspectives on the conversations and feedback that you've had. So I wanted to just set the stage a little. I think you know all of this, but to remind you that the reason we're in an era of competency-based medical education is that previously, when I went to school or Dr. Nimmo went to school, it was a T-steeping kind of model. Training was 4 years, therefore you went through 4 years. You might occasionally got a pat on the head that said, good job. But really in terms of meaningful feedback with your supervisors, not a lot happened there. And really everybody got the exact same cookie cutter training program. And what we've tried to move to a little bit in competency-based education is a focus on the outcomes. What should you be able to do at each stage? And kind of a progression through training that's a bit individualized, depending on your individual strengths and individual weaknesses. And while there's a ton of system things that have been really difficult and maybe have drowned out the original intent, if you feel like you're drowning in assessment, that's often a very common feeling. I think the intent of competency-based education was, can we put more individual attention on the individual learner? That our learners come out of training feeling like they had a better sense of their own strengths and weaknesses as they head out into individual practice. So that's the aspirational goal. And really 4 key principles, focusing on what should you look like, what should you be able to do, an emphasis on your abilities, trying to de-emphasize time, although that's really not how it's played out. Nobody finishes training sooner than they should, but we maybe do things differently for folks who really seem competent early in their training, and really trying to promote putting some responsibility on learners for their learning to help them have that sense of what's my strengths and weaknesses. And so we're going to hone down here around coaching. And so in the competency-based Competence by Design, which is really just Canada's brand of competency-based education, 2 types of coaching are meant to happen for residents. On the left, coaching in the moment, and that's where we're going to focus. That's really us as frontline teachers. What are the conversations we're having with our learners? And then on the right is more this idea of coaching over time, that somebody helps the resident have an eye on how am I doing as I progress through training with all of this assessment coming in. And in your program, that might be Tyler. It might be in smaller programs. In bigger programs, like in internal medicine, we have to have separate coaches for our residents because the program directors, there's 150 residents and they can't do that. So it's broken down. So we're really going to focus over here on the left-hand side of that coaching in the moment. And so that obviously you have to ask yourself, you've been a supervisor, and same for graduate supervision. And for those of you who are just coming, this metaphor doesn't work because this is an old dog doing new tricks. I hope you appreciate that. But that's really what we want to ask ourselves as teachers. Okay, here comes along a supposedly new educational model. They talk about us instead of teachers as coaches on the front line. For those of us who have been doing it, are you asking this old dog to do new tricks? Or is this the same, just a kind of repackaging or rebranding? And I think it really depends on how you view yourself as a teacher or the stance that you've had when you're working with your learners. So if we think about what is coaching, coaching intent is really to guide another through a process. So it's really focused on, can I help this individual achieve the next level of performance? And this is a picture of Ashley Stevenson, who is an amazing baseball player. She was on the national team for, I think, about 15 years. She then coached the national team. And now she's actually a coach with the Vancouver Canadians here in town. So part of the Blue Jays, organization. And just an example of somebody who's been such an excellent coach in helping others achieve excellence in their performance. And a coach's priority, your priority is really about how can I help this individual be better? And so if that feels very similar to how you've been going about it always in your teaching, then I think you won't find much has changed. But if you've had a different stance, like on supervision, maybe you don't take such an individual lens, maybe you feel it's more about your judging, then this may be a place where you might think about shifting how that evolves with your learner. And really to say there's three things that are really relevant to the coaching relationship. Obviously, you as supervisor or coach, the learner and their responsibility in it, and then the systems in which we work. How much of a feedback culture is there in the lab? How much of a feedback culture is that really normal in pathology? Or is it really strange that all of a sudden a supervisor said something about a resident's performance? So all of those things go together to really sort of set the tone for the coaching relationship. Now, I think this is really important to remember. So this is flipping for a moment, and learners, I'd be super interested in your perspective on this, but you will hear endlessly about that our learners need to be in a growth mindset. And so this work comes from Carol Dweck, a psychologist. It's been around for quite a long time. On the right in green are kind of those key elements of a growth mindset. But a growth mindset really means I come to my work with this sense of like, how can I get better? And I want feedback because I'm really thinking about the doctor or the pathologist that I want to be. And a fixed mindset is, I want an A+. I am doing anything to change my performance so that I get a high grade. And I suspect this might be very relevant for grad student supervision as well, kind of what's that stance of the learner. And just to share personally, so I did internal medicine as my training. I was a CTU doctor forever. In about 2018, when I was pretty burnt out, I moved over to palliative care and I went and did 6 months of training in palliative care. And so I got to write PGY 29 on all of my notes because, I've been in the system for so long. But I really noticed, like when I was a resident in my original training, I was all about like survival, getting through, passing the rotation. Did I get a cake at the end of the rotation? Did they like me? And that was really like a fixed mindset approach. I was not reflective on like, am I the internist that I want to be? And obviously I'm much, in a different life stage, but going through training in 2018 in palliative, really I was about like, oh, I know where my gaps are, I think, and what I don't know, where my communication skills are, maybe my pain management. And I'm really out there seeking feedback from the preceptors, from the patients, from the allied health team. So I felt like I was much more in a growth mindset, also didn't really have anything to lose, if you will. But it's really hard to ask this of our learners. Like they have been in an educational system that gives them a grade on everything they do from the moment they entered kindergarten, right? Unless you went to some of the alternative schools. And then they come to residency, because even medical school perpetuates that to a degree. And then you come to residency and all of a sudden we're like, why aren't you embracing your mistakes? Why aren't you okay? Why aren't you more, showing more vulnerabilities? Why are you upset with this feedback? Well, I think if we think about the fact that like moving into a growth mindset is not like an overnight thing. And you've always been in a place where performance counts the most, so fixed mindset, just to have a sensitivity to how hard it is what we're asking for our learners, and for that to happen in this kind of shortened time frame in residency, where I think it happens for all of us, but it's happened as we've gone out into practice and we've been like, whoa, there is no test. My patient is my test. How I'm, that is the feedback that I'm getting, and we've evolved into growth mindset. So I just wanted to sort of frame what we're asking of our learners too, because I think some humility about how hard that would be might be helpful. And there's things we can definitely do to promote that. So our own vulnerability when we're chatting with our learners, sharing what it's like, creating that safe learning environment. We're going to talk about some of this other things, like how we set learning goals and how we provide feedback, and just that we model ourselves. Hey, I didn't know what to do there. This is how I'm going to go out and learn about it. Hey, I just got this feedback. I realized I read this slide wrong. Look what happened to the patient. Here's how I'm changing. Like modeling the growth mindset can be very powerful as well. So I'm going to pause right here, and I'm just going to come off of screen sharing every time I pause so I can see you. So I'm interested in your perspectives. Residents, if you're willing to chat, like I'd be very interested in your perspective of how it feels these days in residency. Like, do you feel like this idea of like, are you feeling like you're constantly assessed? You feel like you have good feedback conversations with your preceptors? Kind of what does that, if you're willing to share, don't, no names, et cetera, but like, what is that like as a resident these days?
Rose, you're very polite because Sarim, Mark, Anthony, what do you guys chime in there? Do you feel like you're being assessed all the time?
Well, sorry, can you hear me?
Yeah, perfect.
Okay, great.
Thank you.
I think, yeah. I think the nature of pathology, like the way we do it with our schedule, with the daily side and everything, where you're like seeing the staff kind of every day, and you are essentially checking your answers every day objectively. So yeah, I do feel like there's that element of always being assessed. Earlier on, maybe the expectations are like pretty low, so you don't feel so bad. And then as you feel like you should be improving, you maybe put more pressure on yourself to be right more often, if that makes sense.
Yeah, totally. And I mean, that would be very parallel to clinical medicine. Same idea, right? Like I'm in the right diagnostic space. Did I order the right investigations on the clinical side? So I hear that is very similar kind of in its realm. Thanks, Anthony. How about on the faculty side? Is there anything this already raises for you, or any antibodies that it raises for you as I talk about this idea of like us as coaches?
I'll go ahead, Krista.
Yeah, I think it's tricky because in the CBD, the focus seems to be on writing down that assessment,
Yes,
not having the moment of feedback. And so almost if I don't write it down, then was it worth doing? I think is for both sides. Like I think that we've kind of focused maybe on the wrong thing. Instead of coaching the resident, how to improve, we're just like, here's your number, it gets sent to your program.
yeah, that's spot on. And that's a very universal problem in CBD. I think there was a fundamental problem in the implementation. There was this intent that if I put assessment in the hands of the resident and they had to ask for it, then more feedback conversations would happen for them or with them. And exactly what you said happened. It just meant now they felt like every day was an assessment day, and it didn't free up that space to actually have those feedback conversations. And one of the things you said that's really important, we'll come back to it, is that the minute something is written down, it pushes everybody into the fixed mindset. Like it is about assessment. And we talk about, look, it doesn't matter. We're going to collect a whole bunch of these. They really don't count very much. But it's actually not that something is high stakes or low stakes. It's really from a resident perspective or learner perspective, it is either yes stakes or no stakes. So that dichotomy has been problematic. And I think one of the things that is going to have to be reeled back pretty hard in the next iteration of CBD is reducing the assessment burden and the frequency of assessment, so that we as supervisors have more space to just be the supervisor. That, yeah, I just want to have a feedback conversation, and the resident feeling like, this was super helpful, thanks for that feedback conversation, but it doesn't need to go anywhere. Like that's just between the two of us, and the resident owning it for their own learning. But I think it's been was kind of a fundamental flaw of the current implementation.
David?
Yeah, so I do mainly research. I mean, I found your discussion on the mindsets really kind of interesting, but I wonder, is it possible for a community of kind of educators and mentors to effectively encourage a growth mindset if the world they live in themselves and the way they treat themselves and their hierarchy operates in a more of a fixed fashion? Or does one need to be fixed to, beyond the individual, more embrace the growth mindset as a training environment?
Yeah, I think if it wasn't kind of who we are, like, then again, it becomes just like I'm playing at the growth mindset, like I'm performing it for the sake of the marks that I'm supposed to look like growth mindset, but it's not actually like who I'm going to be. So I think that's very true. And we talked in the beginning, right? Like there's the learner, there's the supervisor, and then there's the environment. So actually, if our environments are all about fixed, we feel on the hook about, I don't know, job security or how mistakes are handled in our department, what's the culture of feedback, and you feel like, yeah, I work in a fixed mindset kind of system, then yeah, it's not going to work to foster growth for anybody until that culture actually shifts. Otherwise, I think it just becomes, again, a performative act, whatever's happening in the moment. That's a great point. Hey, Cheryl.
Building a little bit on that, I found, your slide, the growth. I would love to get a copy of that slide. It's so but I think, I attended a talk by Martha Piper earlier this week. And some of the conversation was around, the role of our institutions and the learning environments and the ability to give and receive critical feedback. Maybe we're entering an era where, it's so important for our institutions to build those skills and really, the opportunities to learn and be in that mindset are decreasing outside of our institutions. So I think it's going to be a very interesting time in education for not only the professions, but, general post-secondary. So I'm taking what you're saying and broadening a little bit beyond, what is happening with residency and medical education, but more at large, and our responsibilities and opportunities that go with attending post-secondary school for whatever the learner wishes to achieve. So thank you for that.
Yeah, that's super interesting. Thank you for making those stretches. That's great.
Yeah, I must admit, my reaction to that slide was also very strong, and it was, I think, the only time I've been so impressed by a single kind of table like that was when somebody showed me the back of a book by Jane Jacobs, Systems of Survival, on the way society works, and had the same kind of positive reaction. But it really is quite a brilliant slide, and I hope you will share it with us.
Totally happy to share. Yeah, not a problem. You can have the whole slide deck. It's great. Thank you. Michael, shall I continue on? Does that sound reasonable?
Yep. Go ahead.
Okay, so from here, what I was going to do was then just take us to focus on a little bit around our feedback conversations as really a core piece of our supervision and coaching. And I'm put forward a couple different definitions of feedback because feedback sometimes gets your back up. That you think about feedback was like this really negative interaction that we've all remember from any of our training, I'm sure, from the PhD side, the MD side, this horrible conversation where somebody really dressed you down. And so sometimes feedback has that negative connotation. But let's consider that what we're trying to get at is a learning conversation where there's something, I bring certain expertise as the supervisor in the things I've seen, and the learner has some, insights into the things that have happened. And we're having this conversation with the intention, again, that coaching mindset of trying to help improve future performance. You maybe been to faculty education workshops many times, faculty development workshops, where they talk about, don't worry, there's a model for feedback. It's the feedback sandwich. I have to tell you, I'm a vegetarian, so this slide horrifies me. We won't stay here very long, but first I say something nice, that's the bread. Then I tell you the thing I observed, like your slide diagnosis was so incorrect. How could you have interpreted it that way? And then I tell you something nice again, but oh, your communication style was very straightforward. So the feedback sandwich, any of you have either experienced it or tried it. it generally fails. This rarely feels like it's a smooth way of going at having a conversation with our learner when I have something that I'd like to get into a discussion about that, I think could actually help their future performance. And these days in the education world, we've really moved into this idea of a socio-cultural perspective on feedback, that it's a conversation between two individuals, that we try and lower the hierarchy between supervisor and learner, and that we both kind of come at the conversation with curiosity, interested in what the other person's perspective is and the why of that perspective, as opposed to you, the learner, should gracefully, receive anything the wise supervisor, wants to share with you. So it's been a real shift in higher education, slowly, I think, translating down. Of course, it's kind of neat. I have these synergies in my world because palliative care, goals of care conversation, serious illness conversation is so key to our specialty. And that's very much the same idea of like me trying to have an open dialogue with my patient about and understand them in order to try and help them with their decision-making around end of life. So I'm going to lay out a number of conditions that I think are the things to think about. So rather than the way to go at good feedback is use the sandwich, I'm going to lay out a number of conditions that seem to set the stage or help facilitate feedback conversations. And what I'd love for you to do in this is some of these, you might be like, I do this stuff all the time, so that's great. Don't even worry about it. But is there anything in these suggestions that for you resonates a little bit as to something that that's an area I haven't paid attention to, or something I might want to actually work on? And it comes from work myself and lots of other researchers have done, but we had this pretty cool study in internal medicine about a decade ago, where we actually got funding just to go and follow a resident around as their coach for half a day. So I was not there attending. They were on whatever rotation it might be. We would set up a time and I would come for the afternoon and spend that time with the resident. And I had 3 or 4 PGY1s who were mine. And then I saw them 3 times over the course of the year. And there was funding for that to happen. And we just, each time we would say, we'd have a conversation, what do you want me to watch today? And I'd follow them around, kind of like a med student, trying not to intervene. And then at the end of the afternoon, we'd debrief about what happened and what they're working on and what they might be doing for the next couple of months and that kind of thing. And then we did a qualitative study to try and unpack what was the impact of that program on the resident? How did it help or not help? What kind of happened around feedback conversations? And it very much in this mode of the conversations that will evolve, where we'll try to, attain this kind of sociocultural perspective. So I think I have 6 suggestions or conditions. The first is to remember, and I think we've talked already a bit about this, that all feedback conversations, they are interpersonal, they are relational, and emotions will always be present. So it doesn't matter that you think you are objectively commenting on how that resident interpreted a slide, this very kind of scientific objective piece of work. How somebody reads a slide in your specialty is inherent to their identity as a pathologist. So any comment that we have to make does have an interpersonal element to it. It's kind of gets at your identity. It may raise emotions. And so I think you just always go into feedback conversations recognizing that. That's not to say we're not going to engage in them. It's just to acknowledge that actually this is a very relational act and I'm going to attend to, hey, who are you? How do we work together? What are you up to? Those interpersonal social graces that actually help set the stage for having a more honest conversation. And again, you may do this all the time. Super interestingly, a number of years, anesthesia asked me to come and do a similar workshop for them, because they spent all day with their residents. And I was like, well, that's super interesting. Why are they having trouble with feedback conversations? But this piece about hey, at the start of the day, just ask who your resident is and what they're working on and where they come from, 3 minutes out of your day, was a piece that they maybe didn't, because they would get in and really have to get started on the work of putting that patient to sleep. And so for them, this felt like an area that, oh, maybe that's the piece that we've been missing a little bit, that why sometimes the conversations feel rocky at the end of the day. The second bit is, think about if you're going to be in there watching them, or at the end of the day having feedback, to create together what are the goals for this time together. So if your workflow is that you spend a month together on a rotation, resident, supervisor, then it's about, what are they working on for this month? Or if it's a one-off, people move day to day, then it's what would you like to get out of this day that we're working together? And that is co-created. Again, that idea that the resident, if they're going to be in a growth mindset, has to kind of own what their learning goals are. And you might provide a menu, like here are the things that learners typically work on at, at this, on this rotation or in this way. But to think about setting those goals. And obviously, when I think about graduate supervision, that's so much a longer relational piece. That this may be something that you do like intermittently every 3 months. We reset the goals of like, what are the relevant goals to be achieving? For the medical folks in the CBD, I just wanted to point out, this is where EPAs are so helpful. So if we think about EPAs as being that blueprint for what are the things that we should be attending to, what should the resident be working on at this stage in their training, then actually asking them like which of the EPAs they're focused on or working on right now is an easy way into that goal conversation. And similarly for the residents, if it feels overwhelming to think about like, what am I working on? I'm working on being a great pathologist, narrowing down to like on this rotation at this stage of training, which of the EPAs are most relevant can be a really helpful way of thinking about what's a short-term goal that I could actually work on here. And so, whereas right now, I think you might think about EPAs as those assessments that happen all the time. If we actually focus on EPAs as a blueprint that kind of highlights for all of us what's important in our specialty, where we should be developing more competency, I think it can be quite helpful in that way. And that helps with that bit about co-creating the goals and those moments for observation and feedback. So I'm just going to come out here and just see if anybody had any comments about setting the interpersonal relationship or the goal co-creation. Is there anything folks want to chime in on? And I'm very interested if any of the like PhD folks want to comment how relevant this feels also to your graduate student supervision.
Comments, anyone? Rhodes, we're pathologists, so we tend to be very quiet.
Yeah, I know. That's okay. I can wait them out.
David Huntsman's usually got something to say.
Yeah, so I was trying to react and almost shared my screen by mistake. No, it's actually this has been it's a very good idea. I wonder whether this concept of goal co-creation, it obviously can happen micro scale on a daily to weekly basis when you encounter your students and you help them through various blind alleys of experimentation. But probably it should be formalized within the graduate student committee, where there's a discussion about the what next, what the goals are, because then the committee comes back for review. So I think that would be a very, an interesting addition to the kind of mindset of committees. Where,
and it can be quite helpful, I think, on that day-to-day or the check-in periods over time is like, are we still on track around that? Yeah.
Yeah, but that's where, we actually have a funny thing in our department where they have these in-camera sessions where the student is supposed to leave the room and then the committee discuss it, but they really should have a similar one where the supervisor leaves the room and the students can just talk candidly about their supervisor.
Yeah.
But in that, also the whole committee, I think this co-development kind of concept would be really useful. So, I'm not sure if Helen Cote's on today's. Oh, is Helen Cote's there? So I'd love to get Helen's, who runs our graduate programs, opinion on how we could embed this.
I'm just coming in, catching up. Can you just repeat your question? Yeah.
So, well, it was about the co-creation of goals and objectives, and I thought that this would be an educational moment for the way in which we run our committees.
That's true. I mean, we've talked about incorporating career plan in our supervisory committees so that there are short-term goals, but there are long-term goals for the students. And we think it's important for the committee to know what those goals are, because some of our students really want to become teachers, and some of our students really want to continue in academia, and others want to go to industry, and that may influence the type of connections that we provide for them or the type of advice that is given. And so this will this is something that we hope to incorporate in our and then I appreciate your comment about the sandwich, Dr. Hatala.
Yeah.
It is used a great deal, and it does feel a little planned.
Yeah.
And I do people know that. And it's something to work on. Giving feedback in a strength-based fashion, I think is really what we should aim for.
Yeah, and I also think like we focus too much on the message, as if the important thing in feedback is like the message that I'm transmitting. But the important thing in feedback is what the relationship in which the conversation is grounded. And so like you can deliver sort of very critical feedback to somebody to a learner. But if the learner feels like this person is on my side, they're really trying to help me, like everything about our relationship has been like that I know they have my best interests at heart, they are much more open to actually engaging in that conversation with you. And similarly, think about the flip, that if they don't feel safe in those ways, even a positive comment is kind of dismissed because again, they're not feeling like, that's just a superficial comment. Did that really play to my strengths? So we've spent so much time in feedback focusing on the message. And if we actually focus more on the relational piece, the process by which it's happening, that actually is the thing that grounds the ability to have a conversation about whatever message it is that we wanted to leave. So I like your idea about strength-based is a very good place to sit. Krista.
Yeah, I just had a question and more of a struggle with this piece number 2 of co-create goals with sometimes how our service is scheduled. So we often now have maybe 1/2 day, 1 to 2 hours with the learner.
Totally.
So trying to figure out how to do the co-create goals if you have them now and you have them again in 3 weeks on that service or something like that, but only for a brief period of time.
And so all I would mean by that in that situation was like start of the day. Hey, what do you want me to give you feedback on today? What are you working on today? And that hopefully would be like one small thing of what is the work that they will do in those 2 hours. And then then at the end of that session, when you're about to like just sit down and be like, hey, this is how things went in our half day, you can focus on that one thing. So you're keeping it pretty micro at the level. And maybe goal is even too big a word for that, but it gives you a thing. And it also gives you a way into conversation because you're like, yeah, you asked me to pay attention to this. Let's talk about that. And hey, I also noticed some other performance thing I'd like to just chat about for a second if you're open to it. So it also can open the door a little bit easier to other conversations.
I would say a similar approach is taken for when we do peer evaluation of teaching. And it's a part that is not everybody does, but it's an important one. Before the actual lecture that is being evaluated, the peer evaluated and the teacher meet to discuss what are the things that you're hoping to improve or that you're working on with respect to your teaching. And then after the lecture is done, we revisit and see how did you think that went, and were you did and that the person being evaluated can really reflect on the parts that they were hoping to improve upon or modify.
Yeah, I agree, Ellen. And also recognize how that conversation works because we perceive each other as peers. And obviously inherent in our supervision or with our residents, like I am not pretending that there isn't a hierarchy and that we don't have things to share that come from experience, but partly the not attending maybe in the same way carefully to that interpersonal bit and what do you want me to do and how can I give you feedback is a little bit because we come at it as like the teacher who knows more as opposed to my peer where I'm negotiating what's happening in that conversation. So even taking that idea of it, that peer piece a little bit can actually probably facilitate the feedback conversations with our learners as well. So thank you for that. Okay, so that's 2 of our conditions. So let's pop back in and let me just share a few more of the other conditions that, again, you may or may not already be doing in your conversations. I wasn't quite sure how to talk about this one in pathology, so you can help me the most. But when I talk about in our clinical spaces, one of the things that we really encourage in feedback conversations is actually doing some direct observation. So this is meant to just be like being a fly on the wall and watching the learner engage with their patient so that you can provide some feedback on this thing that you've actually seen. In pathology, I'm not sure if that's so much about your discussion at the end of the day. Maybe it's about times when you're thinking about like running the lab or how the learner was communicating with other specialists, something along those lines. But any place that there is for direct observation, I think it has more than just the observation to it. I think that one of the key things it does is it says to a learner, like, you're so important. I'm pausing my work for this 10 minutes or 15 minutes to watch you and provide feedback. And so you are actually like establishing your credibility as an educator, saying that I'm taking this time out and doing this with you. And so that to me is part of the service or the role that observation plays. And again, you'll know best, and we can chat about that in the discussion as to what that actually looks like in pathology compared to the specialties where it's a clinical patient encounter. It's really important in those clinical spaces. So again, I ask for your kind of just you doing some of this lateral thinking, but it's really important to think about how is this an authentic performance? So if my learner's going to be in a growth mindset, then they can't be doing a performance that is just for a grade. And so the very clear example for me is I ran the Royal College internal medicine oral exam for a long time. So if I said to my internal medicine resident, like, I'm just going to watch you examine this patient, they would begin doing physical exam maneuvers like whispering, pectoriliquy, and things that like, I don't even know what they are, and nobody does them. Like you only learn them to pass an OSCE somewhere in second year medical school. And so that was clearly not an authentic performance. And they were doing that performance because they were thinking about me as the Royal College examiner, perhaps giving them some tips. So I would do a lot of work to say, look, I need you to show me how you actually go about that physical exam. Show me your shortcuts. Show me what you actually do when you're with the patient, if you actually want some feedback on your day-to-day doctoring, because I'm willing to provide that. But if you're in this mindset of showing me like your Royal College exam, obviously the feedback I'm going to give you is don't do those things because they're of little clinical help. So again, for you, I'm going to ask you just to try and make that leap for me. But if there's places there where there's things the residents might do that are more performative, that if you ask them to actually show you how they did it, what their shortcut was, how they've sorted out that information, it opens up a space to then give them feedback on their actual skills in pathology that we want them to do. And if I'm very clear with them, hey, this is a feedback conversation. Like, I'm not writing it down today. It's not going anywhere. Let's just have this between us. So that brings us to this point. And this is, Krista, this comes back also to some of the things you said at the beginning. We have to think really clearly. Oh, no, sorry. This is just about feedback as the conversation piece. So we've done this bit a little bit. We've talked about it. That when I want to have the conversation, to try and actually have authentic curiosity about why the performance went the way they did. Because many times the resident actually has a very good reason for why they did whatever they did. Maybe it was the feedback they got last week, or a teaching session, or something that has worked for them, or when they tried doing it the way you're suggesting, something went terribly awry one time. So trying to get into and understand the resident's perspective is so helpful in terms of having a conversation where it's just two people sharing their observations about this performance that just happened and how that might evolve. Things like, this is what I saw, what were you thinking of when you did this? Is that how you usually do this? Are nice ways into thinking of it as more of a conversation as opposed to information transmission. And then this was the piece I thought I was getting to, which is also thinking about very clearly delineating days or times or clinics where you can say, this one is just between us. This is just for feedback. Today is not, I'm not going to write anything down. Because 98% or whatever it is of our residents are amazing. They're very competent at their work. There isn't anything a competence committee really needs to know about what happened between us today. And so from a program perspective, we need a certain amount of data or assessment. But from resident actually getting a space to just be, to get feedback that's not judgmental, to actually be in that growth space, we have to have days and times when assessment is not happening and nothing is getting written down. So especially because Tyler probably isn't here today because he said he was off to Bowen, we can talk about how can we lighten the assessment load, less workplace-based assessments, less pieces of paper, so that we have more days that we can just be a feedback day between ourselves and our learners. And this was just a quote from that coaching study that I told you about a while ago, where in the qualitative study at the end of the day, one of the residents said, you know, from the first session, because I knew I wasn't getting evaluated, I purposely went in there trying to do what I would do as if she wasn't there, so that I, or whoever that was, me or one of the other coaches, could actually give them feedback on their doctoring in a way that they don't necessarily get in another space. So I'm going to pause there as just one more discussion moment. Does anybody want to comment at all about that sort of assessment feedback divide? Yeah, Krista.
I'm obviously one of the extroverted pathologists.
Thank you so much.
So I think this is also where I think a lot of us do struggle, but so for me, I get it. There are days, obviously, I give residents feedback and I'm not doing an EP, I'm not writing it down, and my colleagues are probably doing the same. But then at the end of the rotation, I, as a site lead, am asking them for how did it go with the resident so that I can give them the feedback. And some of that might be taken into account, right? So this is where I struggle with, is it ever, like in a residency, is it ever not assessment?
Correct. It is never, no, but let's go this way. Because our work is all with patients, and like whether it's in pathology, whether it's in one of the, you know, patient-facing specialties, there are always stakes to the things we do. Like there isn't a place, right? It matters. Like it's always going to matter. So that is inherent in our world. The safer the relationship feels between the learner and the preceptor, the more that it feels like you're on my side, you're actually trying to help me, the lesser consequence there is to the fact that, yeah, I do have to tell Krista a little bit about how our time together went. And actually that information can be very helpful because you get the perspective of the 6 people that worked with that person over the month, as opposed to the 3 days they spent with one person. So yeah, there's probably, but there still will have been conversations or comments that I had with my learner that I don't need to tell you in order to tell you why I think they're doing well, or what is the area that maybe if they wanted to work on, they could fix this thing. That wouldn't feel so, consequential or unsettling, because we've had that conversation, me and the learner, and it's in that setting of a pretty trusting relationship. And maybe it's actually something at that point that they're like, yeah, that's a good point. That is a thing I could work on going forward. So it's like, what can you do to lower the impact of that? It's, again, what's that relational tone between those learners and the supervisors, and those spaces in which they're having the conversations. In our competence committee in internal medicine, I'm the competence committee chair, like it's still those ITers that are much more helpful to understand what's happening with the resident than any of those workplace-based assessments. Like we don't get important information from them, but we do from the ITers, because that holistic sense of the faculty is actually really valuable.
It's interesting you say that, Rose, because for anatomic pathology, the same thing. We still do ITers, and a snapshot at a microscope, that's fine, and it's sort of like a checkbox. Okay, you got to do this, blah blah blah. But yeah, the ITer is much more informative to us.
Yeah, totally. I agree. Okay.
Back to you, Rose.
Yeah. I'm going to take us through the last little bit then. And so I think actually the last condition, if you will, was to think about just always is, as supervisor, can you give that person an opportunity to try again for the thing that you were giving them feedback on? So that rinse and repeat idea. So if you see them 3 times across the month, do you have some sense of what was your conversation when you worked with them the first time? And is there an opportunity to say, hey, I noticed this thing went better, or you're still thinking about your diagnosis in this way. Let's look at how you're examining that slide, whatever that might be. Just an opportunity to repeat is an actually incredibly powerful educational moment. And so at the end of the day, to summarize, these are the 6 conditions that we just talked about. And for each of us, just to think about, hey, which of these are going smoothly? And are there any here that are an opportunity for you to, maybe that's a place where if you've been having difficult feedback conversations, you feel like that's a space where I might target changing things up and seeing if the feedback conversation goes differently. At the end of the day, what are we trying to do with our learners? We're trying to create an educational alliance. So this idea that it's a committed educational relationship, that we're both understanding each other and negotiating or co-creating the plans that we're working on. And we're looking to, create these opportunities to use the feedback in practice, very similar to creating a therapeutic alliance with our patients. This is the bit about writing it down. So this is a little bit specific to the MD's kind of thing about what the Royal College asked us to do, which was after this time of coaching, which we've talked about all these things, establish rapport, expectations or creating goals, get some observation and have a conversation. Then they asked us to record it. And this is the piece, I think, where the moment the documentation is happening, it's again shifting us back into that fixed mindset. So thinking again, like we've already talked about where the places where I don't have to write it down. And then that information feeds into the competence committee and the conversations that maybe it's Tyler or maybe it's a longer coach has with the learner to help them understand all these pieces of information coming into them, so that eventually you have those like kind of multiple lenses on a learner's performance that help you understand their competence, and that decision is up at the level of the competency committee, so that it's meant for us on the ground to feel more like our focus can be developmental, can very much be like not the consequence of what I saw, but really how can I help you do this thing better next time? What are some of the suggestions we might have for action on that? And that's really all I had to share with you today. I'm open to having a bit more of a conversation around things. And I'm very interested. I know the learners haven't spoken a lot, and I know also just because of power and hierarchy, it's hard to, but if there's anything you wanted to share from your perspective of times when feedback conversations have felt great or things that really irk you about them, anything there, I'd be super interested in hearing from you.
Thank you very much, Rose. Again, yeah, if the learners wanted to chime in here, and interested to hear from the grad students, if they're grad students online.
Well, we're waiting. What can we do to help ourselves, but also our learners shift from this fixed to growth? Like, I will fully admit 100% fixed mindset throughout my training. Maybe I'm moving towards a growth mindset, but I'm not sure that that's very true. So what can we do?
Yeah, that's an awesome, I think to share your moments of vulnerability are probably one of the most helpful things, because it's really just saying like, hey, I make mistakes. Here's how I go about trying to fix my mistakes. This is why this was important to me or what I was trying to do with it. Reflecting on that within ourselves, because I bet the moments that you are hardest on yourself are not because, I don't know, some test of some sort, whatever that might be, went badly, but because, whoa, that diagnosis I put forward was in the wrong space, or, you know, whatever that kind of error is that you're like, whoa, that's something that I really want to reflect on, and how do I do better at that? And so sharing that moment and thinking about how you're going to fix that, that is the growth mindset right there. It's like, this is what I'm striving for. This is the pathologist I want to be. Here's how I'm working. And then if we can share that with our learners, so that we don't present this cloak of like, we're always super competent, you know, we're getting A+, it goes a huge way to shifting that kind of mindset. And I actually would argue with you, like, I know, I get what you mean. Like, I know we're all overachievers and like, we like to be the best at everything, but I actually think as we're out in practice, there's so many less opportunities for like grades that we're naturally pushed towards the growth mindset, because you're having to think more about what am I working on, or why did that thing sit with me so heavy that it didn't go so well, those sorts of things.
Other comments or questions for Rose? Nothing in the chat.
Hey, Nicholas.
Nick.
Hi. At the risk of sounding really old and crusty, it's curious. You know, I agree. Like, you know, we should always reassess in how we do things in general in life. But has there been any sort of assessment of these changes? Like, do they make better doctors in the end?
Yeah.
Like,
So that is fantastic.
Yeah.
I think so. I'm not deep into the psychology literature. My understanding is Carol Dweck's work is well-grounded in research in higher education. In medicine, like in, it remains astounding that the Royal College took all of us nationally in this direction. You would be shocked with the lack of evidence behind this particular approach. It's actually horrifying. I actually have been a bit of a protester all along the way. And some of my research and other colleagues has actually been to try and gather the evidence to show where it's working, but clearly where it's not. and gather the evidence to say this is the direction we think it should go. So Nicholas, I am with you that I actually was quite opposed to how can you ask the whole country and every program to go in this direction when there isn't great evidence, and like things like knowing that any assessment feels like stakes. You shouldn't build the program in this way. If we know that any assessment feels like stakes, why would you build a program this heavy on workplace-based assessment? So there is a lot of work to be done to say, yeah, different kind of doctor coming out at the day. I mean, that said, I told you my anecdote about palliative care. And again, that might just be about getting older, but it definitely felt like my stance in training the second time round was so different. And I feel like if our learners could be more like, this is what I need for me, they would actually be able to take better advantage of the things we're putting in front of them in residency, as opposed to being so stressed about performance that actually they're not able to take advantage of the learning opportunities in the way that we had hoped. So.
Krista says in the chat that she would have been an anxious mess if she went through CBD.
Yeah, and also like, here's my biases. Like I went to McMaster, I'm so old. I went to McMaster, which was a problem-based medical school. At the time, it was truly problem-based. We had no exams through our medical school. So you had no idea how you were doing. You always were like trying to garner feedback from the boys around you until the LMCC at the end of the thing. So I think I've been somebody who's sat in this space of an anxious mess for a long time, but that's also reality. Like once you get onto the practice, right? Aren't we all a bit of an anxious mess? Because you're like, am I doing a good enough job? So it's more like trying to help how we could structure and work better in that space, which is actually probably more close to what the reality of our workspace is when you think about it.
Cheryl just wants to say thanks, Rose, and fantastic presentation. Please do share your slide deck.
Totally. I will send them. I'll send them off to Amy. Don't worry. Yeah.
Thanks. I guess any other questions, comments? At which point, Rose, thank you. It was an excellent, very interesting presentation. And I'm sort of like Nick, I'm old, and but I'm very interested to hear that again was put forward on the basis of a minimal supporting data, etc. So and it certainly is time consuming. Anyways, before we go, I would like to say to Jackie had a question regarding searching for someone. Is that right, Jackie?
Yes, indeed. So for the graduate program curriculum committee, we are looking for faculty volunteers who would be interested in serving a 2-year term on the curriculum committee, helping us to develop new courses, review courses, look at evaluations from students on instruction, and keep us moving in a forward direction. So if you're interested, we're going to be circulating terms of reference and things again next week. And I ask you please just to reach out to me or Heather Cheadle, the graduate program coordinator, and let us know.
Okay, Jackie.
Thanks.
Now, if I could make another plug myself.
Oh,
I was
okay.
in a meeting.
Ellen, just one sec. Rose, you're welcome to leave if you don't want to hear the administrative aspects of pathology.
Okay, thank you so much for having me. Have a good afternoon.
Thanks, Rose. Excellent presentation.
I just wanted to make a quick plug on a very different topic. It's somebody told me that the medical school student association, queer student association, is looking for queer mentors. And so any physician who would be interested to be a mentor to a group of queer students, feel free to contact me and I will put you in contact. Thank you.
Thanks, Ellen. Thanks, everyone. That's it for the rounds. Very interesting rounds. Again, Nick, great comment. And everyone have a great weekend. Bye, everyone.
Bye-bye.
Thanks, Mike.
I was thinking if Nick is old and I trained Nick, I was thinking, shit, what does that make me?
Exactly.
Scary times. Okay, take care.
Bye, everyone.
Thank you, Mike.